morning. It's my great pleasure to chair this session of a specific lecture by Professor Paolo Camici. Everyone in the room knows about Professor Paolo Camici, very well known in all over the world, professor of cardiovascular disease, many years of work in the UK and Italy, currently editor of the Journal of International Cardiology, and he is one of the experts in the pathophysiology of cardiovascular disease, including hypertension, and we enjoy him in this exciting talk, coronary microcirculation dysfunction in arterial hypertension. Paolo.
Thank you, Kostas. Ladies and gentlemen, good morning. In the next 25 minutes, I will tell you a story that began some 20 years ago that has provided new insight into the understanding of the mechanism of myocardial ischemia, particularly in patients with arterial hypertension. If at the end of my talk in the next week or so you want to refresh what I'm going to say now, you should read this review article that I published with my friends Kaski, Crea, and Gersh in Circulation late last year. Basically, the message we provide in this article is the following. The mechanism leading to myocardial ischemia, and as you know, myocardial ischemia is the #1 cause of morbidity, cardiovascular morbidity and mortality, are several. There are mechanisms that are due to disease of the epicardial, and you know very well what epicardios mean, coronary arteries. So these are the big arteries that runs from the sinuses of Valsalva upon the surface of the ventricle. We have the left and the right. And these epicardial arteries may have two different problems. One is the classic atherosclerotic disease with formation of a plaque that can progressively occlude the lumen of the vessel, and this is the main mechanism of what in English is called demand ischemia, ischemia on exercise. Or you can have vasospasm of the epicardial coronary artery, Prince-Metal angina, full constriction of an epicardial coronary artery. Now, the epicardial coronary artery run epicardios, but then they give these right-angled branches that enter the left ventricular wall. And then they branch into smaller and smaller and smaller vessels that make up the microcirculation. So the microcirculation, which is not visible at angiography because the vessels are too small, run within the cardiac wall, within the myocardium. And the microcirculation can have different diseases that can equally lead to myocardial ischemia. And one of them is that due to structural, anatomical remodeling of the arterioles, that goes back to the old Folkovian concept, that is exactly what you find in patients with high blood pressure. Then there are other mechanisms, including spasm at the level of the microvasculature, so microvascular spasm, as well as extravascular factors that again play a role in hypertension, because you have to think that these small vessels run within the wall, so they are subjected to the compression of the contracting left ventricle. So, for too many years, this is a nice picture taken from Mike Davis' atlas of atherosclerosis. But for too many years, this was considered the only mechanism leading to myocardial ischemia. Particularly after the introduction of coronary angiography some 50 years ago, it was so easy to detect disease of the epicardial arteries. We demonstrated that indeed, as the stenosis get tighter, so this is the percent of occupation of the lumen, 90%, it means that 90% of the lumen is occupied by the plaque, and we know that this progression of disease is associated with the reduction of coronary flow reserve, which is the ability of the coronary circulation to increase flow when there is an increased demand. And this is responsible for what you see at a SPECT perfusion imaging of the defect during exercise. So remember, ischemia due to this mechanism is most of the times regional. However, if we have a look at the evidence, and there is a lot of evidence, just let's take one. This is a paper published in the New England Journal of Medicine by Dr. Patel, and it's a paper on roughly 400,000 patients with anginal pain that underwent coronary angiography. Now, the interesting point was that only about 38% of these patients with angina had evidence of obstructive coronary artery disease. The other 60% had either a low degree coronary disease, stenosis less than 50%, or absolutely normal smooth coronary arteries. Despite that, also the group with normal coronary artery had a high prevalence of angina, 27%, and 70% of all the patients, including those with obstructive coronary disease and those without, had a positive exercise stress test. So there was evidence of ischemia despite non-obstructive coronary artery disease. There is another interesting piece of information to take into account. When you do an angioplasty, 1 year after the angioplasty, although the stent is open, so we're talking about patients who receive 1, 2, 3 stents, 1 year after, the stents are open, but the patient has angina again. 30%. And the percentage goes up to 60% if the patient has diabetes. Now let me show you an example. A lady around 55 years of age. She has a family history of hypertension, never smoked. She's in menopause since 7 years, very, very important. Losing the protection of estrogen. Hypertension, she was herself diagnosed with hypertension during pregnancy, as often happens. For the past 4 or 5 years, she complains of typical anginal pain, mostly during exercise. Sometimes the chest pain is associated with shortness of breath. Recently, she was admitted to the hospital for a more prolonged episode of pain with an ECG showing evidence of ischemia, and the angiogram showed absolutely normal coronary arteries. So this is the resting ECG. This is the ECG when she was admitted. You see clear horizontal ST depression more than 2 millimeters, typical ischemic ECG, but the angiogram was normal. So, but when you do angiography, you only look at this part of the arterial tree. So this is the epicardium, this is the endocardium. And you don't see all the intramural vessels. Now, what you got to realize is that the small arterioles, less than 100 micron diameter, so 0.1 millimeter diameter, very small vessel, they are in close vicinity to cardiomyocytes. So they wrap around cardiomyocyte like this. They form a network. And this is the regulation of blood flow to cope with increased oxygen demand. When you increase oxygen demand, the myocyte will work harder, the Krebs cycle will run faster to produce more ATP, but when you run the Krebs cycle, not only you produce ATP, you also produce superoxide, which is quickly transformed to hydrogen peroxide that diffuses to the vessels and vasodilate the vessels. So whoever created this is a wonderful mechanism, very simple, very well working, that links cardiomyocyte function with vascular function. So the more you work, the more you dilate the vessel, the more flow to cope with increased oxygen demand. And this is where this regulation takes part. You see, when you do angiography, you only see down to this septal branch, which is more or less this, but you lose all this network that is not visible in angiography. Therefore, we propose that in addition to atherosclerosis, to epicardial spasm, we need to add a third box here to account for microvascular dysfunction. It's not difficult to imagine that if something goes wrong in the microcirculation, this can contribute to myocardial ischemia. Does it matter clinically? Does this have a prognostic value? Yes. This is a study we published with our friends in Boston, Marcello Di Calli, more than 700 patients that were studied with positron emission tomography. We measured the flow reserve and found that those with reduced flow reserve, both male and female, had a MACE at follow-up that was much higher than those with a better flow reserve. So it's important. Other recent, very important point coming from the same group. Patients with abnormal microvascular function, with reduced flow reserve, are more likely to develop heart failure with preserved ejection fraction at follow-up. And we know that there is a strict relationship between heart failure, reduced ejection fraction, and arterial hypertension. It looks like this is mediated via the dysfunction of the microcirculation. So how do I diagnose ischemia due to microvascular dysfunction? This is what we propose in a recent paper from the Covadis group published in the International Journal of Cardiology. So you need to have symptoms like this lady. You need to have objective evidence of ischemia like this lady, the ECG. You need to show that the epicardial coronary arteries are not obstructed. And last part is maybe the most difficult to achieve, is to provide evidence that the microcirculation is not functioning properly. So I'm lucky because I can use PET. I started to use PET when I was in London. I have PET in Milano. And PET is very good to measure myocardial blood flow non-invasively and to measure coronary flow reserve. This is an early study we did in pigs where we compared the PET myocardial blood flow with microspheres. You see there is a good agreement. This is a study in normal subject, human normal subject, to show how reproducible the technique is, fairly reproducible. So what you need to do, but you can do this, you have a lot of good echocardiographer in Greece. So you can do a Doppler on the left anterior descending coronary artery, measured flow at rest and following adenosine or dipyridamole, and then take the flow following adenosine and or dipyridamole and do the ratio between this flow and resting flow. This is the flow reserve that shows how much time, how many times the microcirculation is able to increase flow. And normally this is between 2.5 and 5 times. Because oxygen extraction is already high under resting conditions. So if you increase work, you've got to increase blood flow. There is no other way. But let's go back to the case. So patient with predominantly effort angina. I measure flow with PET. Look, this is the map of flow. So it's the left anterior descending territory, all the segments, the circumflex territory, all the segments, the RCA, all the segments. So these are the 17 left ventricular segments, the usual. Here you have resting flow in each segment, the mean, each segment of the circumflex, the mean, and each segment of the right. And this is global mean. So it's the average blood flow in the whole left ventricle. Now, look at the units. This is not semi-quantitative. This is quantitative. Milliliters per minute per gram. Then you give your vasodilator stress. You measure flow again. You see that there is an increase. But look at the flow reserve, which is this divided by this. It's very low. It's 2 or less. So this patient has a severely reduced flow reserve. But compared to the patient with a atherosclerotic disease, the flow reserve is diffusely reduced. So if you do a SPECT, there is no evidence of regional ischemia because it's the entire left ventricle that has a reduced flow. I hope this is clear because it's the... Okay, good. So we did a study where we measured flow and flow reserve in hypertensive compared to control, and you see that maximum flow in hypertensive is almost half of that in controlled subject, although they have absolutely normal coronary arteries. What is the mechanism of this diffuse reduction of flow reserve? The mechanism is that the arterioles that run within the wall, this is a normal one, this is an arteriole of an hypertension, have a thickening of the tunica media. So there is hypertrophy of vascular smooth muscle with some collagen deposition, subintimal hyperplasia. The lumen of the vessel is reduced. But it's not a focal stenosis, it's the whole arteriole that has a reduced lumen. Besides, this wall, this arteriole is stiff. It will not modulate easily. It's like a tube. Just for you that don't believe me, this is a normal arteriole. See the 50 micron mark? This is the arteriole of a patient with hypertension. So the epicardial arteries look normal, but the arterioles are not normal at all. And is this the consequence of high blood pressure? No. It comes earlier, because this is a study we did in the spontaneous hypertensive rat. As you know, the spontaneous hypertensive rat developed, compared to the Wistar-Kyoto control, nice systolic hypertension. But when they're born, they're not hypertensive. At 4 weeks, there is no difference between the spontaneous hypertensive rat and the Wistar-Kyoto. But already at 4 weeks, they have remodeling of coronary arterioles. So this is something that precedes the development of hypertension, and it's probably genetically determined. Now, what is the consequence, the long-term consequence of this issue? So you have remodeling of the arteriole that causes intermittent ischemia. So the tissue around the arterioles becomes ischemic and becomes necrotic, and you may have replacement fibrosis. In the long term, this will progressively accumulate, lead to extensive areas of necrosis that are visible on MR as late announcement, same way we see it in hypertrophic cardiomyopathy. And this is contributing to the highly frequency of heart failure with reduced ejection fraction seen in these patients. Also in those patients who do not have evidence of typical myocardial infarction, because microvascular ischemia eats progressively the myocardium, leading to large areas of scar that can progress to reduce ejection fraction. Or you may develop heart failure with preserved ejection fraction and then go from these to reduce ejection fraction again with a contribution from microvascular ischemia. You are a clinician, so your question is, okay, Paolo, we believe you, but okay, you've shown us that this has a prognostic. What can I do to interfere with this? How can I treat it? Okay? Now, you got to understand that the homeostasis of vascular well-being depends on a group of two factors. Factors that stimulate growth, pro-growth, and factor that inhibits growth. Look at the factor. Top one is angiotensin II. We know that in hypertension, angiotensin II is sky high. Aldosterone, high. Inhibitors, nitric oxide. If you have endothelial dysfunction, nitric oxide is reduced. So the balance will go to the left. And this is why you develop hypertrophy, not only of the cardiomyocyte, left ventricle, but also of the vascular smooth muscle. So this is a study we published in the Journal of Hypertension a few years ago, where we treated a group of patients with perindopril indapamide for 4 months. As expected, both systolic and diastolic pressure fell. There was a significant reduction in left ventricular mass measured by MR. But the most important thing is that maximum flow and minimal resistance were significantly changed. So maximum flow was increased, minimal coronary resistance were reduced. So we could hypothesize that this treatment had an effect on the coronary vasculature. But to prove it, we did a similar study in the spontaneous hypertensive rat, where we could then study the histology, and look what happened. There was a significant reverse remodeling of the arterioles, increase in flow, and reduction of the medial area. Why is that? Because ACE inhibitors increase the concentration of bradykinin, which is protective against growth, and also improve endothelial function, therefore increasing the production of nitric oxide. For those who are interested, there is another study that was done using most of the antihypertensive drug, but there is no time to go into it, so please, you will see the slides on the website, you can look at the paper. Just to finish off, this is not the only mechanism at the microvascular level that can induce microvascular ischemia. Although the one I show you is more prevalent in hypertension, that's not the only one, because there can also be functional changes at the level of the microvasculature, either lack capacity to dilate or increased propensity to constrict. As you can understand, in this case, there is no anatomical remodeling, and therefore there is no evidence of reduction in flow reserve, because there is no physical impediment at the microvascular level. But the problem is functional. So what you got to do is do a test called acetylcholine, inject acetylcholine that, as you know, would dilate normally functional endothelium in this patient in the coronary artery during angiography. So you inject 4 progressive doses, 220, 100, 200 micrograms. You see here the patient start to have his chest pain, but there is no evidence of epicardial spasm. You go to the highest dose, typical chest pain. Doc, this is the same pain I have at home. ST depression, no changes on the epicardial arteries. This is microvascular spasm. So the occurrence of symptoms, ECG changes during acetylcholine in the absence of epicardial disease is due to microvascular spasm. Don't kill me, I know this is complex, but this is how we thought to summarize a diagnostic flowchart to reach the diagnosis of myocardial ischemia due to either epicardial disease or microvascular disease. I don't think there is time to go into details, but again, you will find it in the slides and find it reading the paper.
3 minutes.
So, this is my conclusion slides. Myocardial ischemia can be due to a number of different mechanisms that act alone or in combination. You can have obstructive disease together with microvascular disease. Each mechanism can be investigated using a combination of invasive and non-invasive tests. Understanding the underlying mechanism is the prerequisite for the choice of the most appropriate therapeutic strategy. Thank you.
Thank you so much, Professor Camici, for this excellent talk. We have some time for discussion. You mentioned that coronary microvascular dysfunction is a pathogenic factor for heart failure with preserved ejection fraction. That really is the prevalence of AHF, PEF is dramatically increasing. And up to now, all the studies targeted heart failure with preserved ejection fraction failed to achieve any improvement in the cardiovascular outcome. Do you think that focusing on the coronary microvascular disease may be a new therapeutic target?
Absolutely, Kostas, yes. There is now evidence, both in animals and in humans, that probably the beginning of the process ultimately leading to heart failure with preserved ejection fraction is an inflammatory disease at the vascular level. So it's the vasculature that becomes abnormal and start to produce substances that then diffuse to the tissue and also producing alterations of the cardiomyocyte. I think this must be a target. There are drugs. There is an interesting group of drugs that stimulate soluble granulate cyclase, right? Riociguat, periciguat, I think they could be very interesting. I know there are ongoing studies with this drug, and this really might change the way we treat this phenomenon.
Any question from the audience? Please.
We first heard of microvascular disease in diabetic patients. What is the connection of diabetes mellitus to the microvascular disease of hypertension?
Well, as you know, microvascular disease in diabetes is not confined to the kidney or the retina. There is also coronary disease. So far we thought of the epicardia, but also microvascular disease. Often patients with diabetes are also hypertensive. Sometimes we don't know what comes first, but it's a similar substrate, and I think that at least in part is mediated by the known action of diabetes on the endothelium. So patients with diabetes have evidence of endothelial dysfunction. And this is not the only mechanism, but it's clearly an important mechanism, because the role of the endothelium, in the end, is to adapt the diameter of the larger arteries to changes in flow within the vessel. So when the flow velocity in a vessel increases, the shear stress decreases. This is sensed by the endothelium that produces NO to restore a higher shear stress, so a low Reynolds numbers. When you lose this ability because the endothelium is damaged by lipids, by oxidants, then this process will not function and you start to develop vascular disease. So far we knew the effect in terms of atherosclerosis, development of the plaque, the bifurcation, but most likely this process begins at the periphery and then extends centrally.
Paolo, there is some studies supporting that the epicardial fat has a correlation with the acceleration of atherosclerotic disease. Do you have any data relating epicardial fat with microvascular dysfunction?
No, this is something I never investigated myself, no.
Professor Kanakakis, and then Dr. Dim.
Thank you. In some cases with in hypertensive patients, we can see impairment of flow in epicardial vessel without stenosis.
Slow flow.
Slow flow.
Yeah.
How can differentiate in the microvascular dysfunction with this condition?
Well, I mean, what you see visually when you inject a contrast, normally the contrast is washed quickly. But in this patient, the contrast stays there and is slowly. Why?
Give me one flow.
Because the resistance downstream is high. So the resistance in the microcirculation is high, and the washout of flow is slow. So it's a visual equivalent of what we can measure in the cath lab. It's called IMR. So it's the minimal microvascular resistance. This is what you see visually. So it's a way to, you see the same phenomenon in acute myocardial infarction when you do angioplasty. Sometimes you see that although the artery is open, the flow is slow. And again, and here the equivalent at the tissue level, if you do an MRI, is the so-called MVO, microvascular obstruction. So it reflects what's going on in the microvasculature.
Thank you. Last question by Dr. Dimitriadis.
Thank you, Professor, for the nice talk and all this research you have done so many decades. Do you think that we can also estimate microcirculation using capillaroscopy, and also a comment about the rarefaction as something to be investigated, and a small comment from you also. There is a trend for lower levels to treatment of hypertensive patients, even in the presence or history of coronary artery disease. Do you think that those who have really microvascular dysfunction should not be, do not prefer very low levels of blood pressure to those patients?
I agree with you, yes. I mean, I didn't mention capillaries because there was no time, but obviously capillary refaction is another very important issue. I think the lady to the right of this gentleman wanted to ask a question. Shall we give her the opportunity?
Okay, definitely. Professor Triandafilou.
Otherwise, I would say, We
No.
make
Ladies
difference between
always,
girls and boys,
priority.
no difference whatsoever.
Thank you. Actually, it's a kind of similar. I would like to ask you if there are studies investigating other forms of microcirculation than the coronary, which is more easy to assess. Yes, and with which target organ you have the best correlation if there are these kind of
Okay,
studies?
thank you. This is an interesting question. I try to be short. Unfortunately, no. The answer is no. Why? Because the coronary circulation is quite different from other districts. For instance, you know that it has been developed a way to measure forearm blood flow to test endothelial function in the forearm, and you can do as a measure of peripheral circulation. But the circulation in the skeletal muscle that is that interesting in the forearm works in parallel, means that when you need more flow because you do more work, you recruit more unit in parallel. The coronary circulation works in series, so the resistance are in series and not in parallel. So unfortunately what you learn from the forearm cannot be extrapolated to the coronary circulation. I'm sorry.
Thank you so much, Professor Camici, for this excellent talk, state of the art of the lecture. Thank you.